Good morning. This is Babak Larian, and today we're doing another Parotid Facebook Live question and answer session, which I'm really blessed to be able to do and reach so many people and answer so many people's questions. We're going to start today by a question that I think is very relevant, and the question was that do we need to remove every benign tumor? Is it necessary for them to be removed? So let me flip this around and just give you some of the basic information. In the parotid gland, majority of the tumors are benign, so only 20% are cancers. And 80% of salivary tumors happen in the parotid gland. As you go to the smaller gland, the chance of becoming cancerous increases, right? So that's one point. Next, there are many different types of benign tumors, right? Pleomorphic adenoma being the most common at 72% of the benign tumors, followed by Warthin's, followed by basal cell adenoma, which is similar to pleomorphic, but it only has one of the components of pleomorphic, and going on and on and on, right? But there's many different kinds. There are many different kinds of cancers, even more types of cancers that can occur, most common being mucoepidermoid, followed by adenoid cystic, then adenocarcinoma, and malignant mixed, which is a version of the benign tumor pleomorphic adenoma having become cancerous, okay? But there are very varying degrees of cancers, okay? And then there's also a different kind of cancer called sarcomas, and these are the different types of sarcomas that can occur in the parotid or salivary glands as well. The reason we get such a variety is because the salivary gland is made up of many different components. There are the saliva producing component, the acinus, right, which are covered by muscle cells to squeeze and push the saliva down the tubes. There are different types of ducts, intercalated or intercalar ducts, or striated ducts, and intralobular ducts. And then next to it are sebaceous cell clusters, which are sweat gland-like structures, and lymph nodes, right? And so any of these components can become cancerous. And there were studies to try to figure out how to make salivary glands for patients who've had radiation and are missing their salivary glands, and that led to our better understanding of the salivary glands, that there are stem cells that turn into progenitor cells before these turn into the specific types of cells, acinus cells, duct cells, muscle cells, so on and so forth, right? And so, and you can see from this that each part can turn into a different kind of tumor, right? So, going back to of all these different kind of cells that you see here, pleomorphic adenoma, the most common one, has a potential for becoming cancerous. And that potential is 10% at 15 years, right? So at 15 years, there's a 10% chance, and that chance continues to increase with time, right? So all the other ones, right, are tumors that don't necessarily become cancers. There is a question about Warthin's because there is an incidence of cancerous lesions developing in the background setting of Warthin's, but that may not be. That percentage is very low, and it's not a necessary thing that happens in a high percentage of Warthin's tumors. So really, it's the pleomorphic adenoma that's most concerning. So because the other ones don't have that cancer transformation potential, the choice of removing them is not based on the reason that they may turn into something aggressive and should be removed, like the 72% that have pleomorphic adenoma. So for these patients, I would say, for the patients who have any of these kinds of cancers, benign tumors, any of these benign tumors, the decision to proceed with surgery is very much predicated on what is that tumor doing? Is it What is the behavior of the tumor? Is the tumor continuously growing and getting bigger? Is the tumor pressing on vital structures? Is the first face becoming weak? Is the tumor pushing on, let me show you that, let me turn you around. So the facial nerve comes out of the skull underneath the ear and then becomes two branches, the lower branch that goes to the muscles of the neck and the lower lip. The upper branch goes to the upper lip, smile muscles, eye, and forehead, right? There is a hole in the skull that the nerve is coming through here. Let me draw that for you. So the nerve is coming through that hole in the skull. If a tumor, and we'll draw the tumor in blue, is benign but happens to be growing right next to here and growing kind of inside that canal, it can push on the nerve. It can push on the nerve if this is the hole where the nerve is coming through and the pencil is the nerve. If the tumor happens to be growing here and pushing on the nerve, that can cause the nerve to become weak. So if any of those things are happening, if the tumor is protruding outwards a lot, massively, if the tumor is continuously growing and there's concerns that it may involve the nerve and push on the nerve, if the tumor is small and growing right at the opening in the skull where the nerve is coming out and the nerve is becoming weak, those are good reasons to proceed with surgery. If, on the other hand, you have a benign tumor, right, that is, instead of being massive, and this is not massive, massive would be this, right? If this is a small tumor and you do a needle biopsy and it's benign, and let's say you've had this tumor for 5 years, 6 years, and it's grown very little, then you have options. You can either say, hey, this makes me anxious, I don't want to be worried about it, I want to get rid of it, which is a good reason, right? Then you can proceed with removing it, okay? Because anxiety will make people sick, right? So anything to relieve stress and anxiety is a good thing to do. On the other hand, if you're Fonzie, you're cool, calm, and collected, and you can handle it, and you can say, hey, this thing is superficial, I can feel it easily, I can go do an ultrasound once a year and check to make sure that it's not growing, instead of a CT scan or an MRI, which are more involved, then you can monitor this thing and see that it's not growing. You can not do surgery unless it changes its behavior. So 10 years from now, all of a sudden you see that it's starting to grow rapidly, you can proceed with at that point. You just have to stay on top of it. So that's my advice to patients, is that's why needle biopsy is important to me, right? If you get a needle biopsy that clearly shows you that this is a Warthin's tumor, right? And the evidence, the amount of cells that they were able to get on the needle was adequate enough for the pathologist to clearly see that this is the type of benign tumor that is not going to transform, then you can potentially observe and monitor that tumor. If, on the other hand, you get a needle biopsy that says it's a pleomorphic adenoma, I would suggest removing that, okay? Unless you're 85 years old and unhealthy, right? You have heart disease and lung disease, having a surgery that would prevent something that's benign from transforming into a cancer in the future may not be worthwhile when you balance things out. But if you're 30, 40 years old, and you're healthy and young, and you have this thing, and no matter what the size is, it's best to remove it so you don't allow the potential to change, especially since we live in this environment that's full of toxins and smog and whatever hormones and preservatives and other garbage we're exposed to in our food and water and so on. It's best to remove it, right? So that's my thought. Now, that's not the thought that every parotid surgeon agrees with, okay? And I'll tell you why. I was trained that any tumor or any mass, anything in the parotid gland, don't even biopsy it, remove it, right? And for years and years, I thought about it and it didn't really make sense to me. Why would I remove? If my sister, or unfortunately I don't have a sister, but if I had a sister and had a Warthin's tumor or a monomorphic adenoma, basal cell adenoma, that's 1 centimeter here, it's not visible, I can feel it easily, I biopsy it and it's clear that it's a basal cell adenoma, right? and I'm convinced, and it's not growing, then I'd say to her, monitor it every year. Why do a surgery that potentially has risk? Any surgery has risk. Why do a surgery that potentially has risk with it, right? That's what I would do. Why would I do a surgery that potentially puts her facial nerve at risk for something that may never ever bother her or never ever affect her negatively? Okay, so that's the reasoning why I chose this route and not the route that I was taught. Now the reason that my professors wanted to do the surgery on every patient is because there is a certain percentage of needle biopsies that are wrong, right? They'll do a needle biopsy, say that it's this thing and it's that other thing. But I have found that in my experience, those times when the needle biopsy says something and something else is found, when you actually read the description of the slides, when you go delve into it deeply and look into it, there are things in there that are not perfectly clear, right? And ultimately, the pathologist may end up saying, it looks most likely like a pleomorphic adenoma, but I cannot rule out this, this, and this. Those are the times where I would say you should either repeat the needle biopsy or proceed with surgery because there's uncertainty, okay? I haven't found any patients where they say it's clearly a basal cell adenoma and on the specimen on the needle biopsy is clear, and you go in there and it's an entirely different beast. That hasn't happened for me. And you know, when there is a staging system called the Milan staging system. Let me see if I have that for you. Yes. So this is the staging system for needle biopsy, right? When it's non-diagnostic, there is a 25% chance. When they say it's clearly benign, it's less than 5% chance that there's a cancer there, right? This is very important. When they say there's atypical information on their atypical cells, 20% chance. When they say it's not a benign tumor, but it's something else, there's a 10% chance, right? So if they clearly tell you that it's a benign tumor, then you're in good shape, right? And that's important. All right, so hopefully that helps answer the questions. If you have a benign tumor and it's not the kind that turns into a cancer, you have options at that point. And you need to work with someone who has experience to guide you in that regards and help you make that decision, but also look at the behavior of your tumor, which helps tell you. If your tumor has been there for only 3 months and now it's 2 centimeters, an inch, then it's going to grow and you should take it out. If it's been there 5 years and it's 1 centimeter, half an inch, and hasn't changed much in the past 2 years or 3 years, then it's kind of in a plateau stage and not a growth stage. You have options of monitoring. All right. Now let's move on to a question that just came up. Abby, I've swollen parotid. I've been told it's sialosis. This was diagnosed by sight only. Now my lips and chin are numb. My lips move, are also affecting my speech. Can you advise, please? Abby, first let me clarify something about the nerves. So these facial nerves that you see here, the facial nerves are not sensory. These are only in charge of movement of the muscles here that you see. So muscles of smiling here, muscles of upper lip, muscles of lower lip. So there's no sensation. If you're having numbness and feeling of tingling, then that's a different nerve. And that nerve, let's see. That nerve, actually I don't have, here, there's a side view, I can get it. That nerve comes through a hole in the skull. Let me do it in black. A hole in the skull. The nerve goes, I'll draw the nerve in yellow. The nerve comes out of your skull, behind your jaw. Behind your jaw, it travels. And then comes out of this hole and goes to your lower lip, right? So if you're having numbness and tingling, something's going on with this nerve. If you're having movement issues, where your lip is weak when you smile, instead of having an even lower lip smile, you have a smile like this, where one part is not moving, then that's the facial nerve. Okay, so Abby, hopefully that helps. Now, if you're having sialosis, which means the parotid gland is swollen, and you're having some nerve symptoms, I really strongly urge you to get an MRI, to get a better look at the gland. Have someone pay attention to it. Please see an ENT, an ear, nose, and throat, that's going to give more detailed attention to this, because you may have something important, and it could still be an infection causing this, but you need more attention. So please pay attention to this. It's very important. Okay. Now let me move on to another question that I had. Sorry, you have to see a close-up of my face while I'm looking for this thing. So this is for Lorraine. Lorraine says, in March 2016, I had a parotidectomy to remove a tumor in my right parotid gland. It turned out to be a lymphoepithelial carcinoma. Wow. Tumor encapsulated, margins are clear, albeit small, less than half a millimeter, and no lymph nodes spread and facial nerve intact. Fantastic. Good surgery. I underwent radiation. So far, good, a little more than 3.5 years. I've yet to find another person out there with my type of cancer. Rare as I understand it. It's extremely rare. So, it's so rare, let me show you, that it didn't make it to the list of cancers that the World Health Organization classifies as cancers that happen in the salivary glands. So, your cancer didn't even make the list, an international list. So, being that it's a lymphoepithelial cell tumor, it means that it came from the lymph node here and some of the epithelial components here. So, what the stem cell that was here that allowed this and these cells to form, that was the originator of this tumor. An extremely rare tumor. So, more tumors can occur obviously than this. And I think, although you had a surgery where the tumor was perfectly removed and the lymph nodes didn't have anything in them, and it clearly had not spread, just because the margin was close and there's not enough experience with it, they gave you radiation as a backup to protect you against the potential for recurrence of a poorly known, poorly understood cancer. And I think that's an appropriate thing to do, because you're dealing with an unknown, right? Let me see if there's more to your question though. I have not seen this particular kind of cancer, no. I was also diagnosed with 2 other life-threatening diseases, TTP and scleroderma, in the same year. Wow, that's really interesting. So there was an article that I recently read coming out of Johns Hopkins about the association of scleroderma with cancers. Now, when I was in medical school, I was taught that patients who have scleroderma have a higher chance of getting cancers, right? And I think what this article argues is vice versa, that people who have cancers tend to get scleroderma, a certain percentage of them, right? Get scleroderma because when the cancer starts, it causes something to happen to the immune system, where the immune system overreacts. Scleroderma is your immune system attacking your skin and causing fibrosis of everything under the skin, right? So all sorts of body parts get attacked by the immune system, and everything turns into thick fiber. The skin turns into a thickening. Skin becomes thicker, which I'm sure you're experiencing to some extent. Hopefully it's limited. But it is thought that the cancer actually does something to the immune system. There's a genetic base to it that allows this to happen. Potentially, if someone has that genetic base and have the potential for getting the scleroderma, they also have the potential for getting the cancer. And when the cancer comes on, it sets off a whole set of events. So, more than likely, the scleroderma in your particular case, also Lorraine, came from that very unusual cancer that you had. And I'm sorry to hear you going through it. There are a myriad of things that I'm sure you're going through and trying to explore. But I'll put in my 2 cents about intermittent fasting for you in particular. evolutionarily speaking, when we're born, our stem cells are making us the fetus, and then when they continue to make every component in our body, they make the bone marrow that makes your immune cells, right? And you're 5 years old, you have fresh baby immune cells that are maturing and getting better and stronger and more effective at what they do, and then you turn into your 40s, right? And then 50, and like me, and things are slowing down, right? Because your cells that are now older are less efficient at doing what they do and more prone to making mistakes, which is why these autoimmune diseases, most of them occur later in life. These old immune cells are more prone to making the mistake and attacking your own body. So there's ongoing research about autoimmune disorders and how intermittent fasting plays a role. And the role that it potentially can play, and it remains to be fully understood and discovered, is that when you fast, we think that we lose fat cells, but what we lose is every system in our body sheds cells that are older, less efficient, functioning less well, right? So there is this thought that the immune system will also shed its less effective cells, which are cells that are more prone to making mistakes, so older cells with accumulated toxins and inefficiencies, right? And so they are more prone to making mistakes. And so when you do an appropriate intermittent fasting, and that's thought to be about 5 days of water fasting, hard to do, right? But that sheds some of these older immune cells, and then once you start eating after 5 days, the stem cells get stimulated to produce brand new fresh cells, and you replace some of those less efficient cells with cells that are more effective in what they do. Something to look for. I'm not advocating it, I'm advocating for you to investigate this, Larian, to look into it and see if it's something that you may feel can apply to you and can help you, right? But I think that would be the way to go. Now, the fact that you're 3.5 years out is very encouraging, right? Because cancers most cancers tend to come back. The more aggressive they are, the sooner they come back, and the longer you are from the time of the cancer coming back, the less likely it is for it to come back. That's in generalities, doesn't apply to all types of cancers, but it's a good sign. I wish you the best, Larian. You have a lot of stuff on your plate. I hope it all works well for you, and I hope this session was helpful to you all. If you have any questions, don't hesitate to send me a message. It's truly a pleasure and really a privilege to be able to do this. Have a wonderful day. See you next month.